Quick disclaimer. The Airway Circle Radio podcast has been produced for entertainment, educational, and informational purposes only. All of the content, views, and opinions shared by our hosts and guests should not be a substitute for medical advice. Please consult your healthcare professional for any medical questions. Welcome to the Airway Answers podcast, expanding your breadth of knowledge. Our wonderful host is Nicole Goldfarb. Nicole is a speech-language pathologist, certified orofacial myologist, and an international speaker. Nicole is the owner of San Diego Center for Speech Therapy and Myofunctional Therapy. She has a special passion and interest in sleep-disordered breathing and diagnosing restricted frenums as they relate to myofunctional disorders. In the Airway Answers podcast, Nicole will be interviewing specialists in the airway realm in order to help our listeners learn and understand all of the components to airway-focused treatment. You can help us by sharing this podcast episode with your friends and colleagues. Enjoy the show.
Hello, everyone. My name is Nicole Goldfarb, and I'm a speech-language pathologist and certified orofacial myologist. And this is Airway Answers, expanding your breadth of knowledge. And I'm here with Dr. Michael Gunson, who is an oral and maxillofacial surgeon in Santa Barbara. So I'm going to read his bio, and we're going to have a wonderful interview because I am so interested, as probably most of you are, in questions about the TMJ, jaw surgery, and so much more. So let me first read the bio for Dr. Gunson. He practices at Arnett Gunson Facial Reconstruction in Santa Barbara, California. Beautiful office, by the way. I've been there. It is beautiful. He graduated from UCLA Dental School and Medical School and received his specialty certificate in oral and maxillofacial surgery from UCLA. Dr. Gunson partnered with Dr. Arnett at the Center for Corrective Jaw Surgery in Santa Barbara, California, and their surgical practice was limited to facial reconstruction, performing thousands of corrective jaw surgeries. Dr. Gunson presently diagnoses and treats patients with facial aesthetic and functional problems, as well as sleep conditions. Dr. Gunson's orthognathic and aesthetical surgical techniques provide accurate, aesthetic, and functional results that improve patient health and satisfaction. Dr. Gunson's also an associate clinical professor at Boston University, a resident faculty at Spear Education, and has hospital privileges at Goleta Valley Cottage Hospital and Stanford University Hospital. He loves teaching and lectures throughout the world and publishes research on orthognathic surgery, facial function and aesthetics, obstructive sleep apnea, and the treatment of TMJ arthritis and condylar resorption. This is all great, all up our airway alley, because I think, just to start, a quick thought is that I think we know human beings, the majority, are suffering from some airway dysfunction just due to evolutionary epigenetic changes in the way the human face has changed in the growing pattern. And a lot of us can probably benefit from jaw surgery, me being one of those. And a lot of us, I think, do whatever we can to avoid surgery. There's some who are like right on it, but surgery is probably my biggest fear. So I think maybe sometimes when people see you, it might have been they've tried 10 million other things until they get to you. I don't know. What's your experience with patients when they find you? Have they been avoiding and doing all different other things? Or do you find the majority of patients are like, I need surgery, I'm doing it?
I like that question. It's been my experience in doing consultations that when patients come for the consultation, that invariably they've had treatment, and most commonly they've had a lot of orthodontic treatment. So it's very rare that I consult a patient who hasn't been in orthodontics once, twice, 3 times, or orthodontic treatment for, 5+ years. And I don't know that it's an attempt to avoid surgery, because there are 2 parties involved, and I think the treatment that they were given, and the 2 parties being the family or the patient and the clinician. And so I think on one side of the equation, you have the family, which, nobody wants surgery, especially if it's explained to them that, somebody's going to break your face. And there are ways to describe it that are obviously quite disheartening. But I think at the same time, there are lots of clinicians that don't want their patients to have surgery for various reasons. And the list of those reasons are long in my experience. So I think there's a certain paternalistic approach from orthodontists and others to avoid surgery for fear of financial constraints, for being the one responsible for having them go through a prolonged recovery. I think more often than not, orthodontists don't refer for surgery because of the experiences that they've had with surgical results. The surgery is, and when I say surgery, I mean orthognathic surgery, so jaw surgery. I think they've had results that they don't like, the surgery is known for being not a little, but inaccurate, that the published articles on the accuracy of orthognathic surgery are not great. And so imagine an orthodontist who knows that a patient maybe ought to have jaw surgery, but sending that patient to have jaw surgery and then getting the result back and having the result not be the best result, and then the orthodontist having to deal with managing the bite and asymmetries that result from the surgery. And the orthodontist can't really blame the surgeon. The orthodontist can't say, well, the surgery was inaccurate, because the orthodontist is the one that provided the referral. So it's a pretty untenable situation. So if you take that professional experience with jaw surgery, there are people in my hometown and across the country, orthodontists who will never make the orthognathic surgery referral for those reasons. Also, as soon as surgery comes out of the mouth, sometimes the patient is off to the orthodontist down the street who won't use the surgery word, and they've lost their start. So it's really rough. I think the way to overcome it is, I think most patients, if you can discuss what it's like for them to live within their bodies and have that connection with them, that you understand what they're going through in living in their bodies and that it's not comfortable for them, and that surgery can relieve that discomfort, that most patients are willing to do just about anything.
Yeah, especially those with severe pain, which we see a lot of those patients. So when you said kind of unpredictable or maybe inaccurate, the surgery, orthognathic surgery, is that just because there's different providers, or is it in general, it can't be so predictable?
No, it can be predictable. So I gathered as many research articles as exists on accuracy of orthognathic surgery and the inaccuracy. So if we just look at positioning the lower jaw in the face as intended, so you take the pre-op plan and then you have the post-op result, and you analyze how close to the post-op or close to the pre-op plan the post-op result was, the variance is anywhere from 0.75 of a millimeter to 4 millimeters. And some of those studies actually don't start counting inaccuracy until it gets to, say, 1.5 millimeters. So anybody below a 1.5 millimeter discrepancy would be considered okay, and they wouldn't start counting that as an inaccuracy. So if statisticians and clinicians are weighing the data, what they are saying in their bias is that they're admitting that the surgery is inaccurate to the tune of 1.5 millimeters on average. That bears out in the research. So the question is, why is it inaccurate? Well, a lot of that has been discussed by my partner when he was in practice, published a lot about joint positioning at surgery and being kind to the joints at surgery. And I think that sometimes orthognathic surgeons don't recognize they don't understand where the inaccuracy comes from in the surgery, that it does often come at our own hands in attempting to try to position the joints, or how we apply the hardware, the fixation, the plates, the screws. Sometimes in the application of the hardware, even the technique can result in inaccuracy. So it's avoidable. By all means, it's avoidable, but it requires a lot of focus and attention. And it's interesting even for me to travel the world and listen to my colleagues and look at their websites and appreciate those inaccuracies as being presented even at meetings, looking at the midlines and how they line up in the face or don't line up in the face, because that's the expression of the inaccuracy is really, does the bite line up? Are the midlines in the middle? Mm-hmm. And is there a tilt to the face? And those are the results of inaccuracy with a jaw surgery. So totally avoidable. Mm-hmm. It's hard. And even in my own, and I discovered this early on in my own surgeries, I was like, why am I not getting what I want to get at the level that I want to get it? And that required a lot of self-analysis. Mm-hmm. I hired an assistant to perform symmetry exams and tests. We did our own research on our patients through the years, adjusted, came up with new techniques, and refined. So it requires looking, which is really step one.
And is there, like in this day and age, more or a lot of digital surgical planning that makes the surgeries more accurate?
That's a great question too. So I would say you would have a hard time finding a surgeon doing analog preparation for surgery. It would be ridiculous. It takes a lot of time to do it the old way. So digital planning is pretty much, I think, the norm in planning for a surgery. I think we all plan in this 3D virtual space. I don't think we've all made the conversion to that. Okay. But so the clinician, whether you have again, the saying is modern advances in treatment give us a new way to do the wrong thing.
Yeah.
So some of the ways that we do the wrong thing with digital, for example, is now, before when we were using lateral cephalograms, two-dimensional profile views to plan surgery, we had to orient the profile in space. And it was this dimension only, as you project sideways and you look forward, mm-hmm. We're only orienting in this kind of sagittal plane, this up and down plane. But now we have a three-dimensional object. We have this plane, and this plane now that we have to orient this 3D structure. And this is a very common error in jaw surgery, is to rely on old normative mm-hmm. orientation techniques, such as Frankfurt horizontal to position the head. And Frankfurt horizontal is like, it was created in order to standardize lateral head films across all patients so that we could perform population analysis to look at norms or normals. And it has nothing to do with how people hold their head, how they develop, aesthetically what's best. And yet, if you ask the 3D planning services across the country what the number one technique is for orienting the 3D structure in a sagittal plane, is Frankfurt horizontal. They just say, just level to Frankfurt. And so that's an error. It's an error in how the face gets projected versus how people hold their head. So digital is great. It does allow us to be much more precise. But again, there are lots of places where we can make error. And going back to the inaccuracy of the surgery itself, the digital plan has nothing to do with that. Yeah. It's how you execute in the operating room.
Yeah.
And now, so now we have something new. We have custom plating systems. So they can actually print titanium plates that fit the surfaces of the bone in the jaw's new position. And with cutting guides and screw guides and this 3D directed custom plated titanium plates. And the research of doing that in the upper jaw is fantastic. It's really good. And it allows doctors to put screws where the bone is in the face. So positioning of the upper jaw with custom plates is pretty great. Positioning of the lower jaw with custom plates is not great because it relies on the ability of the surgeon to achieve what we call a centric relation in the office with the patient awake with all their interferences and all their brackets on their teeth versus the position quote, centric relation of the jaw when they're asleep and paralyzed in the operating room with no interferences. So where is that joint position? And if you're making a custom plate based on a joint position in the office where a patient is posturing, which almost everybody does, and then you go to the operating room and you try to recreate that in a patient who's asleep, not happening. So custom plates in the upper, great, wonderful. Custom plates in the lower jaw, not so much. But I think I'm kind of out in the weeds here with, accuracy with the jaw surgery, but these are important things that, my profession has to work through. I think the advances are fantastic. Digital virtual planning changed my career, enables me to go home and be with my family instead of staying in the office doing lab work for hours on end.
Yeah.
So it's fantastic. And planning accuracy. So when you learn to orient the head in its proper position and treat to that position, it's much better too. It's much, it can be more accurate.
Right. Do you find, now I'm totally off the questions I was going to ask, because I'm like, oh no,
Okay.
I'll stay focused. But I'm just thinking, okay, so every orthodontist that I saw, and I, ensured I went to people who are really airway minded, not just looking at teeth, because my bite looked great, but airway and breathing and body posture, they all said, you need jaw surgery. Like everyone said that. They said, we can try other things, but I definitely cannot guarantee you anything that you're going to breathe better, sleep better. These things may help, but you ultimately need jaw surgery. And probably they would have all been happy had I just gone and got surgery, but that I'm the one that's going to avoid that, because I fear that's scary to me. So I did the MSC, and I definitely breathe better, feel better, sleep better, posture's better, but I know for sure that did not completely correct my issues by any means. I feel like I was always a nose breather as an adult. As a child, not so much. I look at my baby photos and I'm like, whoa, I am a myofunctional disaster, mouth wide open, huge baggy eyes, tongue hanging out. But as an adult, I always breathe through my nose. But I felt like my airflow through the nose was a lot better after the MSC. I couldn't breathe with my chin down without going into like a class 3. So I couldn't get any air. And my husband does yoga and all this stuff. And I'm like, I can't do that because I just can't breathe when I'm on my back doing things. After the MSC, I can breathe, get a deep breath of air through my nose without posturing my jaw forward. So there's a lot of like subtle changes that really changed. They're huge changes. I feel like my sleep is better. However, I just need both my jaws like a lot forward. Like I can feel, I just need them more forward. So it helped and it resolved enough, but I know more is probably needed. And I was a child that was a class 2 put in a headgear. So I know my both jaws need to be more forward. And so as I'm just sitting here, I rest. I want to bring my lower jaw like that. That feels good to me. So it's just interesting, but all the orthodontists did tell me you need jaw surgery. And even Dr. Ting, who's my current orthodontist, I think I was telling him about something recently and he's like, just get jaw surgery. Like, so it's interesting. But I did have a question about that. Like MSC, I've heard because it expands at the midline palatal suture, sometimes that can be beneficial before MMA surgery, because does MMA not do a midline split, or can you just describe that process?
Sure. That's a great question. You will hear differing opinions on that matter from different clinicians. So how to answer that question? Let me address simply how maxillary surgery, meaning orthognathic surgery, versus a pad-borne or even rapid palatal expansion, any like a suture expansion versus a jaw surgery expansion. So both expand in the same place. So when you do a suture expansion with, say, MARPE, MSE, whatever the acronym of the day is, or maxillary sutural expansion, you are making the nasal passageways wider. But also when you perform multi-segment maxillary orthognathic surgery, the cuts that are placed to expand the maxilla are actually placed in the nasal floor. So when I do the maxillary surgery, and I can send you some images if you'd like, splice them in like right now, no, in the video, but you can see that the expansion occurs within the nose itself. And so the lateral nasal walls are expanding, the palate's expanding with the maxillary surgery. So then the question is, well, what is this idea then that sutural expansion is or might be better than orthognathic expansion? And as is usual in our profession, I think we are looking at the problem in the wrong place. So my ability, if I go to surgery, my ability to expand the maxilla is completely based on the template of the occlusion of the lower jaw. So wherever the orthodontist places the lower teeth in a transverse dimension, that's where the upper teeth are going, because when I'm done, I need the bite to fit together, right? So is the patient, obviously. So if I go to surgery and the orthodontist has not decompensated or uprighted the lower teeth adequately, my expansion is then limited, right? Whereas if you do a sutural expansion, the orthodontist, in expanding the upper jaw, can then uncouple the bite of somebody whose lower teeth are tipped in towards the tongue from compensation. So having expanded the upper now, the orthodontist is totally capable of decompensating the lower teeth. Whereas I find in preparation for jaw surgery, because of coupling or other reasons, that orthodontists have a really hard time prepping surgery with lower decompensation, with the lingual root torque that's necessary, bringing those roots back into the bone and uprighting those lower molars. It's what I prefer. It's what I really would like to see going into surgery. So then I can expand the upper jaw, the same amount. And they ask that question all the time. Well, Dr. Gunson, how much can you expand a maxilla at surgery? And the answer is whatever I need to. I've expanded upper jaws. The average expansion, I would say, in the office is 5 or 6 millimeters, but 10, 12 millimeters, 13 millimeters of expansion. And being reminded again that expansion occurs at the floor of the nose. So it's, you bring up a good point about yourself. When jaws develop, there are 3 main directions of jaw growth. It's forward, it's wider, and it's vertical. And when there's growth deficiency in an anterior posterior dimension, there's likely growth deficiency in the transverse dimension. So I would say that, yes, you were treated in the transverse dimension, and what you're describing is an anterior posterior dimension. And we also have to, well, maybe we can touch on it later, but we also have to talk about, like, what are we doing functionally as human beings when we don't grow right? What are our compensations? I mentioned the compensations of the lower teeth when the upper jaw is not growing as it should, but there are functional compensations, postural, how we hold our head, how we stand, where we put our jaw. You described it too. You described it very well, wanting to have your jaw further forward. And is that solely airway based, or is there something about your face that requires the lower jaw to be further forward? Something functional, speech driven, or, mouth closure driven, those kinds of things. So, but that's a digression. Coming back to sutural expansion versus orthognathic expansion, they're not very different from each other. Again, back to technique, there are traditional ways of expanding the maxilla at orthognathic surgery that are not as effective as other ways. So where the surgeon places the cuts in the palate can limit expansion or can maximize expansion. So we're back again to technique. And this is something that Rebecca Backow and I, we teach a course in Seattle every year, and we talk about chocolate cake. We talk about how everybody loves chocolate cake. Chocolate cake's amazing, wonderful, delicious, wonderful. We all want to eat chocolate cake, but really, do we? Just because we call it chocolate cake doesn't mean we really want to eat it. My child could make a chocolate cake versus Renault down at the French patisserie who could make a chocolate cake. And those are not the same. In fact, you could give my child a recipe and give Renault the same recipe. It's going to be a different result. So orthognathic surgery is like chocolate cake. You don't, just because you call it orthognathic surgery doesn't mean you're getting the same result, because the techniques are different and it drives a functional and accurate and aesthetic outcome that's different from person.
In any field, right? You can see a myofunctional therapist, a physical therapist, and it might be a completely different treatment. And patients or other physicians' perspective might change because they might think that's what myofunctional therapy is, or that's what physical therapy is based on that provider. So yeah, you definitely want to do your research before having something like a jaw surgery to make sure the person you're going to has a lot of experience in the issues and concerns that you have. And when you were just talking about functional shift of the jaw, wow, after doing these Zooms and watching myself, I had no idea. Like, I know it, my jaw shifts to the right all the time, like all these things. So you start seeing it and noticing it, and you pay attention and say, whoa, my jaw wants to rest forward. And I already knew my posture is horrible, probably to help me breathe. But it's such a cascade of events from childhood. And it makes me think, in childhood, if we can talk a little bit about TMD and kind of the evolution of TMJ problems, maybe you can talk about different types of problems that occur with the TMJ and how those can kind of evolve through the lifespan.
Mm-hmm. Sure. Yeah. So, let's take a really big, broad look at it. Oftentimes the patient comes to the office, right, and says, hey, doc, I have TMJ, right? And really, I often like to be a smart aleck and say, well, yeah, you have two of them.
Right.
And in our profession, we don't do ourselves any favors either by then referring to problems in the face, whether it be pain or other issues, as TMD or temporomandibular dysfunction. That definition, if you look at the research, is so broad and so unhelpful, really, for the clinician, that we get lost in our profession. But I think what we need to do is we need to break out what's truly happening by system and by the experience of the patient. And I think for the most part, we can divide this temporomandibular dysfunction or complaints into three categories. And there is either a problem that is intracapsular, so it's within the joint itself, and that is usually a problem that is generated by ligament and cartilage and or bone related issues of the joint proper. So intracapsular, inside the capsule of the joint. Then the second is muscular. And the third would be neurologic. Those are the hard ones to deal with. But so what do I mean by that? Well, if somebody comes into the office and says, I have TMJ, and you say, oh, I'm sorry that you're going through that. Well, what does that mean? To some patients, it means that they click when they open and close and it makes some noise, or they hear like sandpaper noises in their joint. That's intracapsular, right? That's a disc incoordination. That's a cartilage cap problem in the joint. But if somebody comes in and says, well, I have pain, the best, easiest thing to do as a clinician is say, point to where it hurts. And, invariably they're like here, or here, or they go behind the jaw. They're like here. Mm-hmm. And you ask them, well, does it hurt like right in front of your ear? No. Well, that's not intracapsular. Mm-hmm. Now we're dealing with muscular problems. And then you start getting into areas where it's like burning pain or persistent pain, and those kinds of things are very neurological. Now, having localized the issues, is it intracapsular or muscular, then we have to ask ourselves, well, what causes muscular pain? Mm-hmm. Or what causes intracapsular problems? Mm-hmm. And that's the next big step. So usually, and most often, muscular problems in the face are caused by compensation. Mm-hmm. They're caused by overuse or inappropriate use. You brought up it was great. You're like, I watch myself on Zoom and I'm seeing I'm doing things with my jaw. I think all clinicians should grab their iPads and record their patients speaking, talking, and interacting from the side and from the front, and then slow it down and go slow and watch what they're doing with their mouth and their teeth and their lips. Your mind will be blown at the crazy things that people do with their jaws and their mouth. But we don't see it. We're just talking to somebody. We don't appreciate how people are talking because it's often too fast. So you have somebody, take, for example, somebody with a bit of an overjet, maybe a slight class 2 patient. What does it take for that person, for example, to not lisp? What does it take for that patient to have crisp pronunciation? Because they want it. Nobody wants to lisp. Nobody wants to hear themselves speak incorrectly or be called out for it. So what does it take for that person to do it? Well, it takes advancing the jaw into the S position to overcome the overjet. That constant advancement into that S position all day long, it's going to be a pterygoid problem. So these are the patients that are going to come in grabbing behind their jaws like this. They're like, it hurts here. It hurts here all the time. So, and that's just a speech compensation, right?
Yeah.
Then we have people who can't get their lips together because they're too far apart, whether vertical or horizontally. That's another problem. It's like holding the jaw forward. Pterygoid problem. So then we go to the, well, what if the masseters are activated? Where does that come from? And there's a whole laundry list there. But that's, in our minds as clinicians, if a muscle hurts, it's overused. So then the next reasonable question is, why? Why? What is this person doing day in, day out that is causing them to overuse their muscles? And we have to stop saying things like, well, it's bruxism, it's clenching. Because as soon as you give it that term or that name, while it's a real thing, as soon as you give it that name, you're done. What are you going to do about it? I mean, you're better off trying to discover what it is that's really setting them off. Are the muscles, for example, worse in the morning versus at the end of the day? Are they worse after they eat? These are all functional questions that should help you decide what it is that's the compensation for the muscular problems. So that's a broad introduction to, like, quote, TMD, but that helps form an answer to the question as to why do people get it? And so I've brought up a few, reasons.
So I've written so many notes here because when you're saying it's a great idea, record your patient speaking, slow down the video, which is so interesting. I feel like sometimes I don't listen to people because I'm too busy watching what they're doing. I'm like, oh, wait, what did you say? I wasn't listening. I have to keep that in my mind. But I do notice a lot of people posture that lower jaw forward for the sibilant sound. So for the S, I do it too.
Yeah.
Especially if you need to over articulate, like presenting someone's bio. I'm looking at it, I'm like, wow. It's almost like, should that maybe be the correct functional resting position of the jaw? If you need to posture your lower jaw forward for speech sounds, it probably should be resting more forward structurally, right? It's kind of like a diagnostic.
The jaws need to function with the least amount of effort possible. And so to transition from a rest position to an S position, which is an active movement, it needs to be with as little effort. So then you have to ask yourself, well, what's the problem? And, dentally, for the dentist listening, I like to say when I teach, I like to say that everything I ever learned, everything I ever needed to know about my profession and helping patients, I learned in removable.
Okay.
Now, removable dentistry is dentistry for making dentures. So you take somebody who doesn't have any teeth and you have to put a set of teeth in their mouth. They have to be able to chew, and you don't want them to get knocked out. Nobody likes having their dentures fall out. They have to be able to speak, to chew, to breathe, to move their lips appropriately. They have to do all these things. And for hundreds of years, there have been techniques to figure out how to put a set of teeth in the mouth that are most beneficial to a patient. Okay. But for some reason, all the techniques that we use for putting an ideal set of teeth into somebody's mouth, we barely use on our patients who actually have teeth.
Yeah.
Right? We don't say to ourselves, "Oh, these teeth and jaws are in the wrong place. I need to remake them." That's not our thought process. Whereas in removable, it's like, "Oh, my denture, I made this wrong. I'm going to redo this, and we're going to change the vertical dimension, or we're going to change this or that." But for some reason, like there's a term in removable called closest speaking space, right? It's that space. So what's really cool is the term space, which we need space in our mouths to function, but just not too much space. It's that place where we can speak without moving too far. Closest speaking space. Has anybody making dental implants or deciding where orthodontically to move the anterior teeth, have they ever asked themselves, what is this patient's closest speaking space? And are they there? And if they're not there, how can I put them there?
And is there a test or a screening to do that? Like perhaps you say certain words with the S sound? Okay. 66. Just have them speak? Or it's not particular things, but just a regular conversational sample? Or do you, because isn't there something like, I want them to say 66, like say S's?
Yeah.
Wow. Okay.
Yeah, that's the published. I mean, if you look at the removable books, that's exactly, what they ask.
The test is speaking. Just talk and see what they're doing.
And observing. So we come back to this idea again of put the dentures in the mouth, and let's say that as you're functioning and speaking, the denture pops out. Well, what's causing the denture to pop out? Forces, usually lip forces, or inappropriate tongue and cheek forces. Oh, okay. Well, when somebody's jaws grow incorrectly and there are inappropriate lip and cheek and tongue forces on the teeth, our teeth don't pop out of our head, but the pressure on the teeth moves teeth and causes them to erupt. And then they erupt and move, and then they get in the way, and then they get worn down, and the lips have to overcompensate, and then we get anesthetic, thin, wrinkly lips over time, and they get long and weird. And so while our teeth don't pop out like dentures, our faces truly suffer, but over time, So we go back to your question about, TMD and the development of that from young to old. I think what we're seeing then is inappropriate growth or unhealthy growth with compensation. Throw into that other genetic factors, not necessarily like growth genetics, but other aspects of how we're made, and you get exacerbations. Right? So living in our bodies is really a question of thermodynamics, right? It's like, how much energy are we using? And we can tolerate a certain amount of energy use before things break. And then at some point we reach a level of energy usage where things then just start breaking. And that's the manifestation of dysfunction and breaking, or excessive energy use is truly what we call temporomandibular dysfunction.
Great. I am writing so many notes. Excessive energy use. This is so good. Okay, so a couple things to back up. The percent of patients with TMD in those three groups, would you say you could say like a majority are actually muscular problems? So that's my one question, is what category or what would be the highest percent in like which category? And then my other question is pain patients. Do those usually fall into the muscular category?
So, 100%. I think that muscular problems are the number one.
Okay.
And I think people live with those and deal with those just day to day, and they think it's part of life until it's not. However, I think intracapsular problems like noises, for example, studies have been done on they've done population studies, for example, and they say that 30% of the population has some noise in their joint. That's quite a bit. I guess the question is at what point does noise become high energy or dysfunctional, right? Because that's an important question. we need not treat noise if there's no energy expenditure causing, damage to the system. So I think back in the day, anybody that popped into a dental office, let's say 20, 30 years ago with noise, it was like, oh, we have to fix the click, And in reality, my opinion, noises in the joint, this is all secondary, right? The reasons that these things happen are, again, because of compensations and extra energy that deforms the disc, elongates the disc, elongates the ligament attachments so that the disc is more mobile in the joint. It's genetic for mobility. A lot of patients are not made, their fascia is not made the way that it ought to be, and so the fascia is loose. And so if the fascia is loose, the discs are loose, and that's a problem too. So muscles, number one, intercapsulars, close second, and neurological. The way I think of neurological pain is usually it's either traumatic, so something traumatic happened in the area of the face, or it's chronic trauma. So the constant muscular pain or fascial damage, like whiplash and things like that cause nerve damage to the area, or what we call central pain sensitization. So chronic pain in any one location can cause spread of the pain to the rest of the face as the areas of the brain that are responsible for that pain get sensitized. So usually the neurological stuff is from long-standing issues that are left untreated or unaddressed or traumatic.
Okay. And I've heard people say, or some people say, like, all TMD patients are airway patients, or maybe the majority. What are your thoughts on that?
Don't ever say all.
Yeah, I was gonna don't ever say all and never say never. Okay.
Yeah, exactly. So let's go through the process of what we just talked about. An airway patient, what are their major compensations to not being able to breathe? So, well, that requires a long conversation. Maybe we'll get into it in a minute as to what causes airway problems in general. But the compensations of having difficulty breathing are almost invariably postural, from the jaw to the neck, right? To the back. I mean, it goes all the way to the toes in reality. But if we're just staying in the head and the neck, it's jaw posture, neck posture in order to breathe better. And breathing better entails making sure that we breathe through our noses, closing our mouths, and holding our jaws forward. So is that going to cause TMJ problems? Well, will it cause intercapsular problems? Well, yeah. If you're holding your jaw forward all day long, you're generating stretching across the ligaments, and you're also positioning the disc up onto the anterior aspects of the eminence. You're going to deform your disc, and it's going to have a more anterior position over time, or a repetitive speaking position where you have to translate forward all the time. It's going to elongate the disc. It's going to anterior displace the disc over time as those ligaments stretch out, and as that's the more functional position for the disc itself. So is anterior disc displacement a primary diagnosis? I don't think so. I think for most people, it's a secondary diagnosis from compensation. So now, yeah, airway patients can or tend to have anterior displaced discs. But if we look at it from a functional standpoint, I think that's more informative to our brains than thinking of it more as a syndrome where they just kind of occur together because. But let's talk about this a little bit. Patients that suffer airway problems and TMJ problems together most often are patients with hyperflexibility syndrome. And hyperflexibility syndrome comes in 3 flavors. There are 2 genetic varieties. One is Ehlers-Danlos, and the other is Marfan syndrome. And then we call these connective tissue disorders. They cause people to be overly stretchy and bendy. And then the third is hyperflexibility syndrome, which is basically the trash can of stretchy people that don't have a genetic diagnosis. So they get kind of put into that box. So airway. Your airway is defined structurally by the position of the bones, but it's also defined by the fascia and the what we call collapsibility.
Mm-hmm.
So when you take a deep breath in, you're creating a lot of negative pressure, right?
Mm-hmm.
And that negative pressure pulls on the tissues surrounding. And if that tissue is more collapsible, more stretchy, it'll collapse. It'll come together more readily, narrowing the airway or obstructing the airway. So it's not just jaw position, but it's collapsibility or the inherent integrity of the soft tissues and fascia in the area. So if you have somebody who has a connective tissue disorder, they're going to be more collapsible. And that's proven, that's in the literature.
So those tend to have a higher rate of airway dysfunction.
Oh, yes. Yeah, definitely. Okay. Ehlers, if you take a sample of 100 Ehlers-Danlos patients, the occurrence of apnea in that group is, I think, 30 to 45%. And then if you take a group of 100 Marfan syndrome patients, it's about 40 to 50%. And the reason the Marfan syndrome patients are higher is because they tend to have the face that looks like the face of airway patients.
Yeah. Long face.
Right. Long face, small upper jaw, retruded upper jaw, lips apart. So the Marfan syndrome patients have the craniofacial phenotype of the airway patient, but they also have the collapsing soft tissue.
Mm-hmm.
So, okay, so now we have that as an airway. We know that these patients are at greater risk for airway problems, but what else are they at greater risk for? Well, ligament laxity, hypermobility. These are your patients that can open their jaws to 60 millimeters instead of 40.
Mm-hmm.
And if they can do that, well, they're deforming their discs and stretching the ligaments, and they will have anterior disc displacement, and they will have clicking, popping, and noises, and they will get stuck open, they will get stuck closed with all this disc incoordination.
Are there indications for doing surgery on patients with connective tissue disorders?
I wouldn't say contraindications, but the surgeon better be aware of the risks.
Mm-hmm. Okay.
I can get into those in a minute, but the other aspects of connective tissue disorders that make for a TMD patient, so we know there's airway problems. So what is it that causes the TMD? Well, we talked about the disc displacement and all that, but they also tend to have nerve damage. Okay, so when you can move parts of the body beyond their programmed distance that they're supposed to move, you're actually traumatizing also the nerves in the area, and they generate more nerve pain. Add on top of that connective tissue disorder patients have something called interoception, where they feel everything that goes on inside of their bodies. They are overly self-aware. These are the people that they tell you that they can hear their heartbeat, or they can feel it. They're the ones that if you do dentistry on and it's a little bit high, they will lose their marbles because they can really feel it. Not in a crazy way, but this is their superpower.
Yeah.
Their superpower is that they're ultimately very sensitive. And so then that leads them on a pathway towards the neurological problems more readily. Add to it that they tend to have anxiety and depression at higher levels than the general population, then they have a difficult time dealing with all these issues. So definitely in that group, you have airway TMD all bundled together and interacting together. So that's an example where you will see that overlay almost all the time.
Is it common for that group to not get diagnosed until like teenage or later years? I mean, because I know we have patients in their like 20s or 30s, and our physical therapists are suspecting this, and they're now getting sent out for testing, but patients who have suffered all these injuries and pain and nobody's diagnosed. Interesting.
No, in fact, they often get labeled as malingerers, hypochondriacs, crazy, and it's unfair. And it cuts both ways. So these patients are very difficult clinically to manage. And so clinicians need to be very aware going in that they're in for it. because it's part of informed consent. It's like, I can help you, but these are my limitations because of how you're made.
Mhm.
But at the same time, we need to be very careful as clinicians not to label these patients as crazy. We can't. They're not crazy.
Right.
You can't imagine. So let me explain it another way, to borrow from a good friend of mine, a dentist, fantastic dentist, scientist. His name's Jay Levy. And Jay talks about fascia and the importance of fascia. And he uses a term called tensegrity. And this is an engineering term. Tensegrity is about, when you build a building, the building has to have intrinsic strength to it to prevent it from deforming. But it can't have so much strength that it's too brittle, where it'll break and crash. So there's this balance, and that balance between flexibility and integrity is called tension integrity or tensegrity. So Jay describes that our bodies are that way. And this is in the literature, it's not just Jay, but Jay does a great job of.
I think he did a great presentation. I think it's on the AAPMD, all about this. It was really good. Mm-hmm.
So our fascia holds us together, but we have to move. So then the muscles take over and overcome the tension of our fascia so that we can move around. And that's great. But if your fascia is really loose because of connective tissue disorders, what holds you together? It's your muscles.
Mm-hmm.
So your muscles then are overworking, and that's where all the pain comes from. Mm-hmm. And trying to keep yourself together and held together so you don't fly apart. That tensegrity is really integral. And when you have these patients that don't have it, it's all muscular.
Mm-hmm.
So you're trying to establish a good bite. You're trying to get them to have proper facial function. And it's hard because they're always compensating for the lack of integrity or tensegrity in their system.
Yeah. And there's got to be a lot of balance, because if you're working on relaxing the muscles, then they're going to lose some of that stability, right?
Yep.
So that's kind of a challenge, I would think, for like a physical therapist working with someone with such issues. If you're doing, relaxing muscles to get them out of pain, then I guess it's a whole postural tone issue, right?
Yep.
Because
that's where the Pilates and the core work comes in for these patients. You don't want them to go in, CrossFit wise, for example, because they'll tear something, right? They'll really hurt themselves. But if you do these really deliberate core strengthening type things, that gives them the integrity that they need by developing the core muscles around this loose system. Back to your question about, does it go undiagnosed? And the answer is absolutely, positively, all the time. I've had patients come to my office for jaw surgery, and I take a really complete history, and I've got these kids that have kyphosis, lordosis. They have injuries from sports in high school, dislocations. They've had their arthroscopies already, and not one orthopedic surgeon in the whole process or physician, bothered to say this patient has a connective tissue disorder. They just look at it as
for that. Can they do genetic testing? Okay.
Well, there's physical exam. That's the most reliable. There's actually physical exam, easy physical exam test. There's the Baton score is number one, but there is genetic testing. There are 12 genetic subtypes for Ehlers-Danlos out of 13, and the 13th is non-genetic. So that's the hyperflexibility syndrome. And then Marfan's obviously is genetic. So that can be tested too. So it goes undiagnosed completely and all the time. And it's kind of one of those things where there's not much you can do about it other than what we talked about. Protect yourself, understand the process, strengthen your core, watch out for valve, heart problems, things like that come into play. Be careful with your sports. So it's helpful, but I think the best part is for these people to realize that they're not crazy, that they're not just falling apart and made wrong, but they have this confluence of symptoms as a result of a genetic problem. So then let's go back, just kind of tie it back together. you have somebody who, let's say, has connective tissue disorder as a young child. It's going to be not diagnosed in a young child, right? So now let's say you throw in some unhealthy growth to this situation and they're posturing. Well, now they're posturing against instability, and these are going to be your worst outcomes, right? Excuse me. They're going to be the ones who suffer most through their youth and up and through their teen years. And this brings up an important topic too. I hate to jump around, but I got to mention this. The age-old question, does the bite cause pain? And the answer to that question is not a good one because it's a terrible question. And that's why clinicians through the years argue about this so often, because it's the wrong question. The question really is, how does the patient respond to a bite that is not correct? Right?
Patients.
So our class 3 patients, for example, usually have no pain because they just, and they function, they eat, their jaws move, they chew, their teeth don't align at all, but they don't really care usually. That's because there's not a lot of adaptation. The class 3 patient can't, for example, push their jaw backwards to try and make appropriate sounds, right? So there's not a lot of functional jaw movement. Posturally, there can be some issues, but less likely. But then you go to the class 2 patient.
They're trapped.
They're either trapped by a deep bite or they're set back high angle and they have to compensate for everything. And so the literature bears this out. What type of bite patients have the worst pain problems? And it's the high angle class 2s. So we can't say that bite causes pain, but we can say that when the bite's off and somebody has pain, it behooves us to figure out if it's the bite that's actually causing compensation that's leading to the pain, right?
Yeah. Like A plus B equals C. It's it's the compensation. Compensations are everything. I mean, it really comes down to whatever the structural underlying issue, we will compensate to maintain homeostasis, and that will have negative effects over time. Excessive energy use, like you said.
One last thing.
Yes.
So this brings us to the purpose of the face. And my background prior to dentistry was philosophy and French literature. And when trying to figure out how people compensate, we have to figure out what are the overriding principles of the face, right? What is the purpose of the face? And the purpose of the face is, in order of importance, breathing, eating, which encompasses chewing and swallowing, and then finally communicating, which encompasses speech and facial communication, so expression. Our brains prioritize our facial function in that order. And our brains will accomplish those 3 things at all costs. So when you understand that that's the purpose of the face, then diagnosing the problem becomes easier. What is it that this human being is doing in order to breathe, eat and communicate?
Yes.
That's dysfunctional.
The role of the myofunctional therapist or the speech therapist is that. So we are basically the most important. Because, right? Breathing, eating, communicating. And then it's any underlying dysfunction throughout developmental years can change, has the capacity to change the structural components, and further compensations will ensue. So we need to obviously treat dysfunction as early as possible to prevent maladaptive growth patterns and to prevent further compensations. Because as we get older, these issues tend to get worse, right? Okay, so I'm trying to decide which direction to go because I know we're running out of time. We're going over.
It's fine. We're good.
You have a little bit more time? I feel the philosopher in you. Well, as we're analyzing all this, I'm like, wow, he does have that degree in philosophy because it's so interesting, just thinking about all this. A couple quick TMD TMD questions. Do you think TMD issues can be prevented with proper oral rest posture and functioning in early childhood? And perhaps maybe that sort of airway focused orthodontic treatment if needed. Can that actually prevent such issues?
Absolutely.
TMD? Okay.
Yes.
Great.
So, and going back to this is where I have become Becca Backout and I are really good friends because one, she's an amazing person to begin with, but her philosophy in treating children and intervening early in their growth and development and allowing healthy growth and development to occur, we see this improvement and unraveling of potential developmental problems. Whereas on my side, I see the result of it. So I see all the compensations, dysfunction, and destruction caused by all of the compensating throughout the, youth teen years that result in an adult who's got cosmetic issues and functional issues and pain, et cetera. So it's really fun to see that spectrum. And so, yeah, orthopedically, for example, from the orthodontic point of view, the interventions are important. But I agree, posturally, this is why tongue tie is such a big deal, because it's like, okay, you have a restriction, you have a low tongue posture. I think it'll be interesting to figure out why people have tongue ties. This is a pre-birth problem, which leads me to the next thing. Growth and development doesn't happen when you exit the birth canal. Okay. This kind of stuff is happening really, really, really early. We're talking weeks into development where the mandible starts forming first. And then the maxilla starts to form in response to, and responds in growth and development to the position of the tongue and the development of the mandible itself. So this idea that we preach that the mandible or the tongue drives maxillary growth is proven in utero. Mm-hmm. So the idea that, we're coming up with this idea in life, some people don't buy into it, but we have to, because it's what's happening in utero. And obviously it continues to happen once we're born. So yes, I think strengthening muscles so there's teaching people to use the parts that they have correctly and promoting healthy growth so that they can be used correctly. That's the two goals, right? So, and then if I can make a little comment too about speech therapy. So integral to the whole process is the speech therapy. But just like I turn dentistry on its head with the question of whether the bite influences pain, speech therapy has always been about sounding correct. So the diagnosis is made whether they sound correct, whether they're making the correct sounds. Something speech therapy tends not to do is they tend not to evaluate how much effort is required to sound correct. So that evaluation needs to take place. Like, how much effort is the individual making so that they can sound correct? And that's where the videos come in, and analyzing how the mouth and the jaws are actually moving, as opposed to just listening to sound generation. So,
right. You've got to watch and see. And that's also where it's important to know that myofunctional therapy is not taught in speech therapy graduate programs, at least at this point. I think it's in the process of being integrated. So the myofunctional is looking at the muscle and the function, and not all speech therapists have that training. And when I got that training, I said, oh my gosh, my whole world was turned around, because all my evaluation process, everything was different, because you see things through a different set of eyes. And then I have to say this one quick quote, because my mentor had said this about posture and function. Posture is the foundation of function. Every muscle movement is influenced to a lesser or greater degree by the posture from which the movement began and to which it returns. And when we're talking about orthodontic skeletal changes, we call the physiologic rest posture how the mouth should rest, with the tongue gently suctioned to the palate, front, middle, back, lips closed, slight dental freeway space. She said the physiologic rest posture, the various structures involved, forms the single greatest determinant of either continued normal function or eventual relapse. So in myofunctional therapy, one of our primary focuses is on getting that correct rest posture. And we need to combine that work with the skeletal work of the dentist, the orthodontist, the jaw surgeon, to get the structure right. We work on the function, get the medical components treated, whether there's allergies or breathing issues, enlarged tonsils, tongue tie, and all those pieces can come together. But I just always think of that when we have our patients who might have a lisp. Of course, the tongue is going to push forward if the tongue doesn't fit in the mouth and rests low, because that resting posture is low and forward. We need to correct muscle function and rest posture and then the speech, because you can't expect someone to move their tongue up and back when it just rests low and forward. So that's where myofunctional therapy plays a role in the speech portion. Is the speech disorder is a symptom of the underlying rest posture problem and soft tissue dysfunction. It's a symptom of. And when you don't have the training in myofunctional therapy, you just treat, drill and kill speech sounds until the patient's burnt out, or it takes years and years to resolve. But if you treat the underlying soft tissue and postural dysfunction, the speech can just happen so much easier. So it's just really interesting. So like when looking at a child, do you think you can predict that's going to be a future TMD patient just by looking at facial structure or profile in a child?
I'm going to be honest that I don't have a lot of interactions with children clinically. Okay. So I think that question's probably best suited for pediatric dentists or a orthodontist.
Okay. And also, when you do a jaw surgery on an adult or a teenager, what's the youngest age you would do any orthognathic surgery?
So the preference is for growth cessation, that growth is done.
Okay.
That way we're not treating a moving target. This is a problem because when I first met Christian Guilleminot, who is father kind of sleep medicine in the United States, his question to me was, well, how early can you get in there? Because we have to fix these problems earlier. So how early are you willing to operate the jaws? And the answer is, orthognathically, I'm not. But now we have all these interventions, expansion, protraction, distraction, and things like that we can do that are not orthognathic surgery. But so to answer the question, growth has to cease. And growth cessation occurs anywhere between 16 and 22 years old, depending.
Okay.
The standard way of assessing growth cessation among orthodontists was always to take a hand wrist film, to see if the bones had fused in the hand wrist. And that's a great technique to figure out when the hand is done growing. But it doesn't inform us as to the face. So facial growth, the best way to assess the cessation of facial growth is to look at the actual condyles of the mandible. And when the condyles of the mandible appear corticated, they have a white outline to them, then usually we can be assured that facial growth has stopped. And so I usually operate, the earliest I've ever operated was on a 15-year-old, but I had to consent the family that I might need to do it again. Like, we did it for psychological reasons. There was a very kind of obvious facial deformity and they wanted it fixed. So I said, okay, I don't recommend it. The joints, in patients where joints are unstable, the jaw surgery is unstable. And in class 3 patients, for example, who are still growing, you can set the bite and then that mandible just keep going after you're done. So I wait for growth to stop.
Okay. And I would assume most of these airway jaw surgeries, the cosmetics of the patient is actually enhanced. Like when I look at these before and after photos, a byproduct of putting the jaws where they should be is that, I mean, obviously there's planning and you want things to look good, but when the jaws are set back, there's going to be, excess soft tissue and, the facial structure should be more forward for better cosmetics also.
So chocolate cake.
Okay. Now I'm hungry. Okay.
Well, no, I mean, you can put the jaws. The answer is it depends. If you follow, this is an important discussion. So let me give background. Where we decide to put jaws traditionally has been established by normative research. And in our discussion today, I don't know if you noticed, but I strive hard to never use the word normal. Because normal is a measure of average. And when analyzing normative data, it's important for us to understand what that means as human beings. but you can't apply normative data to an individual, a single person, because that person's not part of that data set. And that person doesn't necessarily sit under the 66% of people that make up that average. And if you treat to an average, you will always have an average result, which nobody wants. Everybody wants an excellent result. So the issue here is that you can take some of the work that's been done about how in the United States, the normal is maxillary retrusion. So if you're going to base where you put your maxilla on all the cephalometric analyses that have been studied throughout the years, you're going to end up with a recessed maxilla because that's the average. Okay? So technically, if you put the jaws where they should have grown to in the face, the aesthetic outcome will be amazing. Right? Because you've done a couple things. You've supported the face, not just the airway, but you're supporting the lips and the face the way that you're supposed to. So they will have the projection in the face that's aesthetic. And then because the muscles are relaxed, the muscles express themselves in greater fullness. So the lips are more full, the cheeks are relaxed, the mentalis muscle doesn't flatten or ball up. And this is all considered very aesthetic. So yes, if you set the jaws in their maximum projection in the face for full support, and again, here you need to be really careful because if you push too far forward, you're going to make it hard for people to close their mouths around the jaw bones and the teeth. And that's unesthetic and dysfunctional. So what you end up doing is, for the sake of making big airways, you've now made patients mouth breathers because you've pushed too far forward.
Which could lead to relapse, I would assume, too.
Yeah, and sleep disorder.
That chocolate cake, that perfect chocolate cake, right?
There's a place.
The right recipe, the right cook, the right chef.
There's a place to put the jaws that maximizes aesthetic and function. And, that's the clinician's job to figure that out, but not based on any normative study that's ever been done. And there's a trick to that, which obviously we don't, that's like a whole day course on where to put the parts.
It's an art, right? To everybody's specialty, the work you do, it's an art, a skill, and it makes perfect sense, that chocolate cake analogy.
Well, and it's interesting that you say art, because I'm not a fan of art in jaw surgery because you have artists like Picasso. So you don't want to make Picasso faces with jaw surgery. When we call it art, what we're saying is it's that part of what we do in science that we can't explain. And so my goal has always been the part that's artistic, I have to figure out. You have to be able to explain it, not just in order to better our profession, to explain it to other people, but we truly need to understand what we're doing. So like I have colleagues who are amazing. Like they present their post-op orthognathic cases and people literally are clapping in the audience because the people look so amazing. It's like, is that art? And they do. They tell them, they say, oh, you're an artist, and he is. But if you break down why he's so successful at creating faces, I can tell you very scientifically why. His techniques and his positioning and the things that he does actually lend itself to those very successful results. And then the opposite is true. If you don't like the way that somebody, like, again, back to the orthodontist can say, I don't like sending my patients for jaw surgery because when they come back, they look like they've had jaw surgery. Right? So I can tell you why. The common mistakes that are made in orthognathic surgery that lead patients to look like they had jaw surgery. It's like the patient who goes to get lip fillers. They're the ones that you look at and you're like,
what happened to that person?
Not great. And then they're the ones that you never, ever know. Because the person knows how to make lips that look aesthetic and functional and beautiful. So that's the difference.
Yeah. And that makes perfect sense to not call it art, but it's a skill, right? A level of a skill, a scientific reasoning. It's not like
I don't mean to disagree with you because it can be art. Art just means that I can't tell you how I'm so good at what I do.
That makes perfect sense. This has been so great. I'm going to just sum up some of the things. I took so many notes, but we talked about sutural expansion versus orthognathic expansion. We talked about the different categories of TMD, the intracapsular, muscular, neurological, and the majority of pain patients and the majority of issues might fall into the muscular category. You talked about closest speaking space, the functional movement of the jaw, and how we need to look at our patients from a functional perspective, watch them speak, slow down the video. When people are not in a good structural position, they're going to probably compensate and the faces will suffer over time. And you called that dysfunction from excessive energy use. I love that. That is such a good thought because our bodies will break down over time from compensating. And whether they break down in the area we're compensating or referred areas or mentally, psychologically, right? Our patients, we see that. And these compensations can cause the face and the joints to deform, elongate. The purpose of the face, breathing, eating, communication. Those are the three main important reasons for our face. What does it need to do? How do we make that easy, pain-free? No compensations for that functioning person. And when we compensate, we see postural compensations. You said from the jaw to the neck to the toes. This is where also our PTs come in to help unwind the compensations. And then the disc displaces and the ligaments elongate and stretch. We talked about airway, bones, fascia, tensegrity, which I love that term. And Dr. Jay Levy does great information and presentations on that. And we talked about connective tissue disorders, and those patients aren't crazy. They are feeling things, they're superpowers. And that's really important for us all to know. And a lot about TMD, and this has just been so enlightening. I have a page of notes, and I feel like this was so informative to colleagues, to patients. I'm going to spread this podcast everywhere. People are going to really benefit from this information. So I thank you so much for this hour and a half of your time on a weekday. I know you are so busy. So we are just so delighted that you were able to give us all that information. Thank you so much.
Thanks. It was great. It was fun talking to you, Nicole. Thank you.
Are there any courses or anything you want to talk about that any upcoming things or a website or anything?
Well, I mean, I brought up before that I teach a lot and have a lot of courses. I have an orthognathic surgery, orthodontic course here in Santa Barbara. But I think more importantly for your audience, from myofunctional therapists, speech therapists, dentists, pediatric, orthodontic surgeons, the whole gamut, postural rehabilitation specialists, sleep specialists, the course that Beck and I teach over 3 days in Seattle is where that's at. We've had Linda D'Onofrio, who I just love and adore, who introduced me quite thoroughly to speech and myofunctional therapy, came, and it was just a wonderful experience and exchange of ideas. And we all felt, we're all motivated by it. So this course is meant to teach these kinds of ideas, how to identify these issues in kids, how we can intervene in kids as early as we can, and then fast forward to how to unravel all the compensations. And so that's late October. I think it's the fourth week of October in Kirkland.
What's the name of the course?
Healthy Growth, Healthy Faces.
Okay. And do you have chocolate cake served there?
Yes, chocolate cake. Yeah, t-shirts of chocolate cake. And
no. Oh, that's funny. Actually, I have seen that posted. Okay, that's great. So I'm going to try to attend that because that sounds like a wonderful learning opportunity. Yeah. Thank you so much for all of your time and look forward to talking with you soon.
You got it. Thank you.
Take care. Bye. Thanks so much.
Thank you for listening to our radio style broadcast, where we bring different perspectives to the airway world in an easily digestible format. Different hosts, different views, same airway talk. Don't forget to leave us a review. Bye-bye.